Good evening, respected seniors and my dear friends. Today we are going to witness Ahmedabad Obstetric Gynecological Society, the Golden Jubilee Oration, which is going to be delivered by Dr. Patrick O'Brien. Can we have a CV of Dr. Patrick? Yes. Good evening, respected seniors and my dear friends. Today we are going to witness Ahmedabad Obstetric Gynecological Society, the Golden Jubilee Oration, which is going to be delivered by Dr. Patrick O'Brien. Can we have a CV of Dr. Patrick? Dr. Patrick O'Brien is a Vice President of RCOG. He is a consultant OBGY at University College London Hospital. Respected seniors and my dear friends. Today we are going to witness Ahmedabad Obstetric Gynecological Society, the Golden Jubilee Oration, which is going to be sorry for some technical problems. I repeat, Dr. Patrick O'Brien, he's a Vice President of Royal College of Obstetrics and Gynecology. He's a consultant at OBGY at University College London Hospital. He is the Chair International Division of Institute of Women's Health London. He's a member of NICE Guideline. He's a reviewer of the International Journal of Obstetrics and Gynecology. And his area of interest is in high-risk obstetrics, anti and intrapartum fetal monitoring, labor ward management. He's going to deliver the topic of direct and indirect effects of COVID in pregnancy. I handed over the mic to Dr. Patrick O'Brien. Can we have his screen share?
Hello, can you hear me okay?
Yes, sir. We are all eagerly waiting for your talk.
Fantastic. Let me just share my screen with you then.
Yeah.
And let me know if you can see it. Okay. You can see okay?
We are not able to see. Yes, now it's okay. Yes.
You got it. Fantastic.
Yes, sir. Good evening,
Wonderful.
sir. Good evening, sir.
Good evening. Good evening. It's a real privilege to be here, even though it's virtual. And I'd much prefer to be there live, of course. But this is the world we live in at the moment.
Yes, sir. On behalf of Ahmedabad Gynec Society, we welcome you on this very important talk on effects of COVID in pregnancy. Thank you, sir.
Thank you. Okay, for the next half an hour, I'm going to talk about the effects of COVID in pregnancy. I'm going to talk about the two different aspects, and that's basically the direct and the indirect effect. Now, of course, you don't need me to tell you that the pandemic has had a huge impact right across the world, not least on pregnant women and gynecological patients and us, our staff and our families. And I want to distinguish throughout this talk between the direct effects and the indirect effects. And by the direct effects, of course, I mean the effect of getting the infection, getting the virus infection during the pregnancy. And by indirect, I mean not the effects of the virus itself, but the effect that the pandemic has had on outcomes of pregnancy as a result of changing in attitudes of women, in the attitudes of doctors and midwives and nurses, changing society, difficulty in transport, difficulty in accessing healthcare, and so on. All of those indirect impacts of the pandemic. So I'm going to focus for a little while on the direct effects and just bring us back to the relatively early days of the pandemic. This paper was published in June 2020, and this is from UCOS, and this is the UK obstetric surveillance system run by Marion Knight and her group, but which we work very closely with the RCOG. And this is a paper that we published back in June 2020, looking at the early information that we had about the characteristics of this infection in pregnancy. And this is a sort of systematic review that we published in Lancet eClinical Medicine soon afterwards that took that UCOS paper into account. And from an early stage, it became clear that the risk factors for getting bad COVID during pregnancy were pretty similar to the risk factors for getting bad COVID in the rest of the community. In other words, coming from a Black, Asian, or minority ethnic group, being overweight or obese, or having a chronic comorbidity, in particular hypertension, asthma and other pulmonary diseases, and cardiac disease. And those groups of women were overrepresented in hospitalizations and in patients getting the virus in the first place. And back at that stage, we could see a hint that maybe pregnant women were more affected by this virus than people who are not pregnant in terms of ICU admission, intubation, and maternal mortality as well seemed to be increased a little bit, although thankfully from a very low baseline. And it was clear even at that stage that the chances of being admitted to ICU with COVID increased according to the presence of those comorbidities and according to maternal age. But probably the best place to get information on the effect of this virus in pregnancy is what's called the Living Systematic Review and Meta-Analysis. This is from the WHO group, who are based in Birmingham, here in the UK. And this was the first iteration of that publication. And it was the 1st of September 2020, so a year ago now. And what they found is that, yes, pregnant women seem to be more likely to need intensive care. And the conclusions we had from all of this information a year ago was that, number one, the risk factors for getting COVID, getting bad COVID when you were pregnant seem to be similar to non-pregnant people. It didn't at that point seem to be any worse. The infection didn't seem to be any worse in pregnant than in non-pregnant women of similar age, apart from the fact that ITU admission seemed a bit more likely. And I'll be updating these data on this conclusion in 1 second, so bear with me. And even at that early stage, a hint that there's an increased risk of preterm birth and increased risk of cesarean section, possibly. But interestingly, even at that stage, we recognized that the vast majority of preterm birth were iatrogenic. In other words, it was not that this virus was causing the woman to go into spontaneous preterm labor, it was iatrogenic. In other words, doctors felt that the woman needed to be delivered in order to improve oxygenation and improve options for her care. And at that point, it was clear that few babies, amazingly, seemed to get infected with this virus. And of the few that did, very few seemed to have serious infection. Now, Living Systematic Review means that as more relevant data becomes available, this meta-analysis is updated. And the most recent update is still back in 10th of March of this year. And what did they find? Well, indeed, they confirmed that this infection is worse in pregnant women than in non-pregnant people of the same age. It doubles your chances of being admitted to intensive care, doubles your chances of being ventilated, of requiring ECMO, increases the risk of preterm birth by about 50%. But again, the vast majority of those are iatrogenic and not spontaneous preterm labor. It increases the chances of the baby being admitted to neonatal intensive care by a factor of 5. And again, that's largely effective prematurity rather than babies sick with the virus themselves. And stillbirth is something I'll keep coming back to during this talk. But even then, it was a suggestion that the chance of stillbirth was increased by a factor of 3, although thankfully from a very low baseline. So small numbers and difficult to be certain of this effect at that stage. Then there was a paper from the National Maternity and Perinatal Audit, looking at in England and Wales, looking at all the births in England and Wales over an 8-month period during the pandemic. And there were 340,000 births, of whom 3,500 had tested positive for COVID or SARS-CoV-2 at that stage. And again, confirming that stillbirth was doubled, preterm birth was doubled, preeclampsia, interestingly, seemed to increase by a factor of 50, by 50%, I should say, and emergency cesarean section increased by a similar proportion. Okay, so those are all the direct effects. I want to spend the next sort of 10 minutes talking about the indirect effects of the pandemic. And the first hint of this came from a paper that we published back in July 2020. And this was a small study based in one hospital in London, St. George's Hospital, a teaching hospital in central London, and looking at stillbirths. And what we compared then was the incidence of stillbirth before the pandemic and during the pandemic. And if you look first of all at the stillbirths, the top column here, the numbers in brackets are the rates per 1,000, And you can see that before the pandemic, the rate of stillbirth was 2 per 1,000. During the pandemic, it was 9 per 1,000. And even if you excluded late terminations for fetal abnormality, and we thought that that might potentially be relevant because of people turning up late in pregnancy and having scans late because of the pandemic. But even if you excluded those, you can see that before the pandemic, the rate of stillbirth was 1 per 1,000, whereas during the pandemic, 7 per 1,000. But the really interesting thing about this study was that none of these women who had stillbirth tested positive for COVID. Now, of course, there was limited testing available at that stage, but it did not seem to be due to a direct effect of the infection in these women. And therefore it began to question at that stage whether the indirect effects of the pandemic might be contributing to an increase in the risk of stillbirth. And at that point, other countries, other studies were published that did in fact suggest an increase in the risk of stillbirth. There was one, that one from the UK, there was one from Nepal, and then one from India as well, all suggesting the same thing. So we wanted to try to work out why this might be, and we did a further study, again going back to St. George's, and looking at whether women were turning up for antenatal care, for routine antenatal care, at the same rate that they were prior to the pandemic. And if you look at this, this is sort of this is the beginning of the pandemic, the vertical line here. This is when the first lockdown began, and this is when the first lockdown ended. And this is looking at attendance for obstetric emergency and activities. So this is the day assessment unit, the place that women come if they're concerned about reduced fetal movements, or they've had a little bit of bleeding or some pain. You can see that following the first lockdown, there was a huge drop in attendance for these sort of not very urgent types of care. Now, we published this in Lancet ID, and then we went on to have a look at these data nationally, and you can see these are the St. George's data, 20%, 19% reduction in the attendance for those sort of care. When we looked at the equivalent sort of study nationally, this is published in the British Journal of Obs and Gynae, you can see that that pattern of a reduction in antenatal care was mirrored throughout the whole of the country, and I guess internationally as well. So 70% of obstetric units reported a reduction in antenatal appointments, half of them a reduction in postnatal appointments, 60% of units temporarily removed the offer of home births or births in a midwife-led care unit, which are associated with a lower chance of intervention. 86% of units reported a reduction in emergency antenatal presentations. That's what I was talking about a minute ago in relation to St. George's Hospital. And 90%, of course, switched over to the use of virtual consultations. Now, why was this? Well, if you think back, at least in the UK, what was happening at that point, every single day, every single night, people were turning on their televisions and seeing on the news what a disastrous situation. They were looking at people dying, people in intensive care, rapid spread of the disease, and people were very, very frightened. People were staying at home, trying to avoid the risk of infection themselves. And also, I think in fairness, people realized that the health service was really stretched. And out of altruism, they were deliberately staying at home, trying to avoid putting extra strain on what they could see was an already stretched NHS. But the net result was a dramatic reduction in antenatal care. The issue of preterm birth was a very interesting one, I think. And if you look, there were at that point began to emerge some stories, some publications suggesting, interestingly, a reduction in preterm birth overall during the pandemic. So initial study from Denmark, then one from the Netherlands, then one from Ireland, which is my home country, all suggesting the same thing. And this prompted the Office for National Statistics, the ONS here in England and Wales, to look at some of these data. And first they looked at stillbirth. And if you look at the dotted line, this is kind of the average stillbirth rate over the previous 5 years, whereas the bars here are the stillbirth rates month by month during the initial sort of stages of the pandemic. And you can see that reassuringly, they suggested that there was not an increased risk of stillbirth in England and Wales during those initial 9 months of the pandemic. Now, it has to be said that, two things really. One is that you can see, if you imagine, or if you look carefully, maybe a little bit of a blip in April and July, and those were the times of the peak incidences of infection in the UK at the time. Also notable was the fact that in the previous 5 years, the rate of stillbirth in the UK was decreasing year by year by year, and that decrease was lost during the pandemic year. So, you know, some reassurance there, but still more questions remaining to be answered in terms of stillbirth. What about preterm birth? Well, again, some reassurance there. These different lines are the different categories of preterm birth according to gestation, and looking over the previous 5 years and the pandemic year, and no suggestion of an increase in preterm birth overall during the pandemic. Now, I'll come back to these 2 points in 1 second, just bear with me. This is a paper that we published in the Lancet Global Health, and this was looking, not comparing women who had the virus with women who did not have the virus. This was comparing pregnancy outcomes before the pandemic with pregnancy outcomes during the pandemic. And this is stillbirth, which I'm going to focus on first. And if you combine all the studies that have been published comparing before the pandemic with during the pandemic, and you look down here at the bottom line, put everything together, you can see that the risk of stillbirth is increased. This little diamond lies to the right of the vertical line, meaning that this is a statistically significant increase. And it's a 30% increase during the pandemic. And it's likely that some of this are due to indirect effects, at least, and some possibly due to the direct effects of the virus as well. We couldn't tease that out from these studies. But look, very interestingly, if you divide out the type of country in terms of income, and first, if you look at low and middle income countries, you will see that this 30% increase in stillbirth was statistically significant. However, if you look at high income countries only, even though this diamond is still to the right of the vertical line here, it does cross it, which means that this difference, this increase of 40%, was not statistically significant, and lower numbers, lower baseline rate of stillbirth in these countries. This is a very interesting finding in this study that we published, I think, which was surgery for ectopic pregnancy, largely ruptured ectopic pregnancy. And you can see that surgery for ectopic pregnancy during the pandemic was 6 times higher than prior to the pandemic. And I guess this makes a lot of sense. It really reflects this tendency during the pandemic of people to stay at home when they had bleeding or pain in early pregnancy. They were reluctant to go to the hospital. They were reluctant to seek medical help for fear of infection or overburdening the health service. And that translated into a much higher risk of ruptured ectopic pregnancy. And another significant increase, and you'll not be surprised to see this, is much higher levels of anxiety and depression in pregnancy during the pandemic. Not in the least bit surprising. And we're still seeing the fallout from that at the moment in the United Kingdom. Women who had their babies during those first few peaks, those first few surges of the virus, report how difficult and stressful a time it was because of worry about themselves, worry about their babies, and worry about their loved ones. Maternal mortality also showed an increase, and remember, this is still a meta-analysis comparing before with during the pandemic, and definitely an increase in maternal mortality. Not possible from this study to tease out which effects were direct and which were indirect, but most likely a combination of both. And then coming back to this subject of preterm birth, and if you look and put together all of the studies from all different countries, you will see that there's a suggestion of a reduction overall in the risk of preterm birth, but again, not quite statistically significant. It does cross this vertical line. But again, if you separate out high-income countries from low and middle-income countries, you will see that the reduction in preterm birth overall in high-income countries was statistically significant. And this is in spite of what I said earlier, showing that women who are admitted with COVID to hospital, we know that there's a 1 in 5 chance that their baby will need to be delivered preterm just to facilitate the adequate treatment of the woman. So in spite of that, overall, there was a reduction in preterm birth in high-income countries by about 10%. And this is really important, given the importance of preterm birth in our specialty and the burden of perinatal and child morbidity and mortality that it causes. This is something that we really must look into and we must get to the bottom of. And I'm sure investigation into this effect will last long after this pandemic is gone. And again, if you look at low and middle income countries, there's a tendency towards reduction in preterm birth overall, but it was not statistically significant. Now, apart from those impacts on pregnancy outcomes, you don't need me to tell you about the effects that this pandemic has had on the way that antenatal care and labor ward care is impacted. And if you look at the way labor ward was infected, sorry, I should say, it's a Freudian slip, was impacted during the pandemic, you know, we had more or less the same number of pregnant women. Initially, it looked in the UK that there would be an increase in the birth rate. People were joking that, you know, people were stuck at home and they had nothing better to do. But actually, when we got to the end of the year, counted up the numbers, there had been a small reduction in the overall birth rate. I guess people were considering that it was a bad time to have more children. But the big issue was the reduction in staff. And remember in those early days when we had very restricted availability of testing, that anybody who got a cough or a cold or a fever, or who had somebody at home who had a cough or a cold or a fever, had to self-isolate for 10 days. So we were losing staff hand over fist. As well as that, people were redeployed, and doctors from and midwives from labor ward were being redeployed to help out in ITU and A&E. After a while, an appeal from the RCOG to the government that our doctors and midwives were very specialized and their work could not be done by any other specialist. They finally gave us our people back and did not redeploy so much in the second and third waves. On the other side, because of the cancellation in all the gynecology elective work, we did have help from extra gynecologists, although some of them had to be drawn a map to show exactly where the labor ward was because they hadn't been there for many years. And then, of course, we all know that fever is common in labor for all sorts of reasons. And whenever somebody got fever in labor, because we didn't have access to rapid testing, they had to be treated as if they were COVID positive, which involved full PPE, etc., etc. Now, I just wanted to touch on where we are right now in the UK with this new variant, the Omicron variant, which I'm sure you've seen is sort of rapidly spreading across the world. Started out in South Africa, hit here no more than 2 weeks ago. And these are the data in number of infections yesterday. 88,000 infections in the United Kingdom yesterday. That is the highest since the pandemic began. And the vast majority of these cases are Omicron variant. It's rapidly taking over as the dominant variant in the United Kingdom, and it's pushing the Delta variant out of existence very, very quickly. So you can see how the numbers have shot up in the space of 2 weeks. And they reckon that probably this 88,000 represents only about half of cases, because of course not everybody is coming forward for regular testing. So that's the number of cases. Now, if you look at the number of hospitalizations, however, you can see that they have not increased significantly. This is up to the 12th of December. And if you look at the number of deaths up to yesterday, there's not a significant increase. Now, this means one of two things. Either, as the people in South Africa are saying, either this variant is milder than the previous variants, and we certainly hope that that's the case, or that there is a lag phase. We all know that there's a lag phase between the spike in infections and the spike in hospitalizations and the spike in deaths. So we're holding our breaths at the moment, and we reckon it's going to be another 2 weeks or so before we answer that question. Is this just a lag in hospitalizations and deaths, or is this truly a milder variant? The reports from South Africa, as I say, suggest that it's a milder variant, but it's notable that the population in South Africa is very different to the population here. It's in the UK, at least, it's a much younger population and largely unvaccinated population. So we're waiting with trepidation to see, but to be cautious, the government has stepped up sort of lockdown procedures here again. So we've taken a step backwards here in the UK. Okay, what else happened during the various lockdowns that we've had? Well, because of lack of staff, water births were stopped, also because of fear of infection being transmitted during a water birth. Home births were stopped. That was largely due to a shortage of midwives and a real stress on the ambulance service. And then for a while, partners were stopped. Even some hospitals stopped partners from being present during labor and during cesarean section because of the risk of infection. We at the RCOG and the Royal College of Midwives made an appeal and thankfully stopped that very quickly, so partners were allowed to be there for the birth. But still, for most of the pandemic, partners were not allowed to be there for antenatal visits, for ultrasound scans, and an hour after the birth, they had to leave and could not be with the woman in the postnatal ward. And the effects of that are still being felt today. You know as well as I do the evidence that shows that if you have a trusted partner with you during the whole of the labor, it does reduce intervention. And we have many women now still telling us about the trauma that they felt after having their baby, not having their partner there to help them or to support them when they were going through a difficult time during the recovery. So significant impact. And let's come back to that right now, because of the effect of this Omicron variant, we have a huge number of people off sick. So in my hospital, University College Hospital in London, we have 20% of midwives off and 20% of obstetricians off. So we are really struggling with shortage of staff. And the advice for self-isolating is changing almost by the day. So Omicron came along just 2 weeks ago to this country. At that point, the rule was that if you came in contact with anybody with the virus, you had to self-isolate at home for 10 days. That changed pretty quickly, and it became that if you had contact with the virus, you did not have to self-isolate at home. You could come to work, but you had to have negative lateral flow test every single day. But if it was the Omicron variant that you came in contact with, you still had to self-isolate at home for 10 days. Then, just 4 days ago, the advice was updated again, and it said that if you came in contact with anybody outside your home, regardless of whether it was Omicron or another variant, you could come to work, but you just had to do a lateral flow test every day. But if you're in contact with somebody at your home who was tested positive, you had to isolate for 10 days. And now, literally half an hour before I came on this call, on the Zoom call, the guidance has been updated yet again. And what it says is that regardless of any contact, whether it's in your home or whether it's outside the home, regardless of the variant, you can come to work as long as you do have a negative PCR straight off and a negative lateral flow test every day. And you can see that this is the government responding to the dramatic stress and strain that our units are under, our hospitals are under at the moment, mainly because of lack of staff, not because of a huge increase in the number of cases, which may be yet to come. Okay, in terms of antenatal care, you know, the change to virtual appointments was dramatic. When I do an antenatal clinic now, if I see, 20 people in a morning, there will perhaps be 1 or 2 in person and all the rest would be virtual. And there's also been a significant reduction in ultrasound scans, although not the important scans, but the scans that were being done for the softer indications, dramatic reduction in those. And then a big changeover to home monitoring in terms of glucose home monitoring and home blood pressure monitoring. Now, there have been massive advantages to this changeover. The whole point of introducing these was to reduce the risk of infection to the women themselves and to the staff. But also, there's been a huge improvement in women's care in the sense of the convenience, not having to travel to the hospital, saving costs because of that, not having to organize childcare for the other children, not hanging around in busy antenatal clinics for an hour to see a doctor or midwife. So definite advantages. And there's no doubt that when this pandemic passes, a lot of this will be kept. However, there are potential disadvantages to this approach as well, and particularly to those at greatest risk of bad outcomes. And these are people who are vulnerable or who have safeguarding needs, women who are subject to domestic violence, women who have difficult communication. So for example, in this country, where English is not their spoken language, or if they're deaf. And it is entirely possible that this has contributed to poorer outcomes. And you know yourself, it's, the little clues that you get, if you're seeing a woman in the antenatal clinic and her partner's there, the little clues that you pick up on, the non-verbal clues that this woman is afraid of him or being abused by him, those are largely lost when you're speaking to somebody over Zoom or over the telephone, and you just cannot see who's standing on the other side of her screen, and you lose all that non-verbal communication. I just want to mention gynecology as well, and this gives you an example, a taste of what happened to elective procedures. This is not just gynecology, this is all elective procedures in the United Kingdom. And you can see this is 2019, the number of elective procedures that took place, and the lower line here are the elective procedures that took place during the pandemic. And during the lockdown in particular, you can see this blue area, the deficit, the lack of cases that should have been done electively. And we have a massive backlog of elective cases. We were starting to catch up a little bit, and now this most recent wave has hit again. But a huge backlog to deal with. Now, much of that backlog, of course, was in sort of benign gynecology, benign pathology, and this was kind of waiting times over 18 weeks. And you can see it was pretty low and took a huge increase during the pandemic. And patients were waiting over 52 weeks for the referral or to be seen in a hospital was almost zero for a long, long time. And you can see how that rocketed during the pandemic. But it was not just benign care that suffered. Here's cancer care, and the different lines here represent different parameters, and most of them were pretty okay. So first consultant appointment within 2 weeks of an urgent GP referral, maintained. First cancer treatment within a month of decision to treat, maintained. But look at this light blue one. Look at the huge dip during the first peak of the pandemic. And this is first cancer treatment within 2 months of attending a national screening service. So a huge drop, a huge delay here. And that, of course, has the potential to be translated into more cancers and later presentation of cancers. Now, for 1 minute, I just want to mention the college, the RCOG, during this time. And when this kicked off just back in March of 2020, we, group of officers, president and vice president, we'd literally just taken office a couple of months beforehand. We were just getting used to our jobs, and suddenly this hit. And really, this kind of dominated our work for the next few months. And we were literally updating this guidance every few days. There was a huge demand for some sort of guidance about COVID and COVID in pregnancy. And we produced this initial guidance, COVID in pregnancy, which now is just a few weeks ago, published version 14.2. It's been updated many, many times during the intervening period. And that main guidance of COVID in pregnancy gradually mushroomed into a whole suite of guidance, covering just about every single aspect of our specialty, including restoration and recovery, which has got off the ground barely a couple of times, but keeps on being pushed back and being pushed back. So please have a look at this. These guidelines have been downloaded over 5 million times. It's the most downloaded and the most viewed of any publication of the RCOG in our history, for obvious reasons. And I just want to finish by bringing you right up to date. This is evidence published just yesterday, again from UCOS, the UK Obstetric Surveillance System. And this is showing maternal mortality according to, well, two things really, but maternal mortality according to the different waves, the different variants of this virus. Now, if you start down here, you will see that the rate of maternal mortality was 1.4 per 100,000 live births. This was when the wild type, that was the initial variant that came across to the UK. Next was the next wave was the alpha period, where alpha variant was the dominant variant, and the maternal mortality rate, 3.2 per 100,000. Next came the delta variant, and you can see 5.4 per 100,000. So there's a strong suggestion here that these three variants have become more virulent, certainly in terms of pregnancy, and there's some data, some equivalent data for non-pregnant people as well, but a real suggestion that these variants have become more virulent, certainly in terms of pregnant women with each iteration. The hope, of course, is that this new variant, the Omicron variant, will be milder, but we don't have evidence to answer that question just yet. The other key message from this publication from yesterday is this, and this is looking at all of the women admitted to hospital who were COVID positive or SARS positive during the period from May 21 to the end of October 21. This graph is for women admitted to hospital. This is for women admitted to intensive care. The blue dots, or the blue boxes, are those who were unvaccinated. The dark brown box, those who had 2 doses of vaccine, and the light brown box, those who had 1 dose of vaccine. And you can see of all of those admitted to hospital during those time, 96% were unvaccinated. And of all those admitted to intensive care during that time, pregnant women we're talking about here, 98% were unvaccinated. So we are using these data to try to persuade women to get the vaccine and to show them just how protective this vaccine is against getting COVID, against requiring admission with COVID, and against been admitted to intensive care with COVID. And I'll stop there. And I hope that we will soon be coming to the end of this. If there's anything good about Omicron, it's that number one, it may turn out to be milder infection, although as I say, we can't be certain of that just yet. The other thing is that even though the next 4 weeks we think will be awful here in the United Kingdom, it does look like this is going to be a very rapid spike. It looks like it's going to rise rapidly and probably reach a peak quickly and then drop away rapidly again. So we're all keeping our fingers crossed that that'll be the case. Thank you very much indeed.
Thank you very much, sir, for crisp and clear-cut ideas about the COVID direct and indirect effects of COVID in pregnancy. So many things that we knowingly or unknowingly what are the indirect effects of COVID infection in pregnancy as well as in general populations. Thank you so much for your the data and all the role of vaccine also that you just summarized in the last slide, that the role of vaccine is very important in this pandemic. So
thank you very much indeed, and thank you to Professor Gandhi and to the whole organization for inviting me. It's a real privilege. So
I request Dr. Alpesh Gandhi sir to have regards from Ahmedabad.
Thank you very much, dear friend Patrick. As always, it is always very fascinating to attend your talk, and this oration was excellent. You have rightly selected the topic, very recent topic, recent infection, recent topic, recent pandemic. At Foxy also last year we have started our own registry, National Registry of COVID-19 in pregnancy. We have observed that infectivity, severity, infectivity, mortality, cesarean section, everything increased, stillbirth, everything increased in the first wave, but it was not that much, there was not that much severe difference, significant difference was not there. But during second wave, we have observed that the severity, infectivity, need for intensive care, stillbirth, everything increased like 5 to 7 times or 8 times more. So it was very dangerous. Second wave was very dangerous. Thank you very much. And it was very, the topic is very, very required because there are some misconception or impression, wrong impression that men are more affected with COVID than women. But actually, if we consider direct and indirect effect, both the things, then probably women are equally or more affected than men. In men, usually 80% are having some comorbidity, whereas our obstetric patients are younger and they do not have comorbidity. Only 35 or 40% women, obstetric women who are having COVID infection, serious COVID infection, are having comorbidity. So though pregnancy is not a comorbidity, it has significant effect when they are affected with COVID-19. So thank you very much for bringing, and some indirect effect, like they are not reaching to the hospital because of fear of getting COVID-19 infection, and some stillbirths are there because of this. Similarly, they are not going for abortion. There is already great deficiency in abortion services in South Asian countries, and because of this COVID, this pandemic, it has further decreased, and it has created many significant unsafe abortion or increased mortality. Indirect effect, some girls have lost school educations, and now they are not going to return to the school. So what we have achieved in last 2-3 decades for women education empowerment is overall is at threat, not only the health. So that, thank you very much for bringing this direct indirect effect and selecting this very recent topic. Thank you so much. You all are very excited and very and this is our very prestigious oration, Golden Jubilee Oration, and I think Dr. Jignesh Delivara, our president, will inform you about this oration and citation.
Thank you, Abish.
I request Dr. Munjal Pandya, our honorary secretary of AOGS, is going to read the citation and it summarize the the history of this Golden Jubilee Oration. Dr. Munchal. Yeah.
Thank you so much, sir, for a wonderful oration. We would like to have a brief history of AOGS Golden Jubilee Oration. That is, in the year 1986, Ms. S.C. Pandya was the organizing chairperson, Dr. R.M. Nadkarni was executive chairperson, and Dr. S.R. Parikh was the organizing secretary. AOGS had completed 50 glorious years in this year. It was in this year when the Golden Jubilee Oration Trust was formed. And this is one of the orations on behalf of AOGS, that is Golden Jubilee Oration. I'm just reading the citation. Ahmedabad Obstetrics and Gynecological Society feels honored and has pleasure to award the Golden Jubilee Oration for the year 2021-22 to Dr. Patrick O'Brien, date 17th December 2021, Friday, subject the direct and indirect effects of COVID-19 in pregnancy. Sir, we are eagerly waiting to hand over this particular scroll and memento in Indore in All India Conference in January 2022, sir. Thank you so much, sir, for the wonderful deliberation of the oration and enlightening us with direct and indirect effects, along with the statistics and in such a simplified manner, sir. Thank you so much, sir.
Thank you very much. It's a real honor.
Pat, are you coming to Indore?
No, I had my flight bought, and then they brought in the new regulations, which was when you arrive in India, you have to isolate for 10 days. So I can't do that. Eddie Morris was due to come as well. He had his flight got, he can't come. Rani Thakur is coming because she can stay with her family in Mumbai for 10 days and then go on. But we're so disappointed. It was going to be our first trip since we took over in December 2019. This is going to be our first trip. So we thought, oh no, not again.
So you are always a permanent feature in all our AICOG. This time we missed.
I really miss it. I would love to go there. I'd have to say, especially All India Congress is so fantastic. There's so many people and so many old friends there. I'm really missing it.
Thank you. Thank you.
All right. Thank you very much, guys. Enjoy the rest of your